Everybody
I'm
okay
good.
there?
Nice to see you.
Yeah, good to see you too. So we have a, can you see me? Can you hear me?
Loud and clear.
Okay,
I'm joined by Kevin Proch
that,
from the Brigham and Women's, Gresh Wardekar, who's an interventional radiologist who's making sure you follow all your radiation and use the right views, and Dr. Mustafa.
fantastic, Ziad. Thank you very much. And we have a nice case here. With me is Dr. Vijay Kumar, who leads imaging and physiology at MMM. There is Dr. Reddy, who's my fellow. There's our nurses, we have the techs here, all of us showing you a very nice case. So let's go to the history, please. Can you have the history on the... So this is a 70-year-old gentleman. He's diabetic, hypertensive. He had an anterolateral wall MI in Kerala and had a primary PCI to the LAD using a 275 into a 40 millimeter drug-eluting stent. This is at the KIMS Hospital on 7/5/2021. He came here to see his son and had a pre-syncope on 25/7/2021. Came and saw us. His echo showed a moderate left ventricular dysfunction. His ECG showed a lateral wall MI. His urea creatinine was slightly on the higher side. We'll show you the angiogram. Because of his history of syncope, we worked up for syncope, including a Holter. And the Holter was not showing any bradyarrhythmia. He didn't have any bradyarrhythmia. When he came in, his troponins went up during this admission. So obviously there were some issues related to ACS, and he had an angiogram done. So I'm not going to show you the older angiogram, but here is today's angiogram, where you can see the right coronary. Can you see the left coronary or the right coronary is yet?
The left. We see the left.
Yeah. Okay, so the right coronary shots show that there's some disease in the right mid-segment. There's about a 50% stenosis in the right. And so we went ahead, took the other view on the right, and you can see the other view on the right showing again a 50-60% stenosis.
Yeah.
They can go live.
Yeah, and then we went to the left shot, and you can see the left shots now. Okay, anyway, before we did the left, we just checked an RFR on the right side, just to be sure. I will show you the left after this. But we can show the left possibly and then come to the RFR. Just go to the left coronary shots. Yeah. Angio left, please.
No. Oh, yeah.
Okay, so you can see the left shots now. And there's a tight left main disease there on the ostium. The stent looks okay on the angiogram. And as I told you, the right seemed to have some disease. So the plan was to check the right, whether that is flow limiting, and then obviously tackle the ostium of the left main. So just for the initial discussion, just for people who are not very conversant with functional testing, so this is the right wire.
The live, please.
Can you have the live on the right? Yeah, it's okay.
Go back one.
Yeah, so Vijay, can you go through the functional testing now?
Yeah. Good evening, everyone. So if you see today's angiogram, right, it doesn't appear to be that tight, at least in a lower view. So we thought anyway, we opened the pressure wire, we checked this hemodynamic significance of this vessel. So we did an RFR on this vessel. Just see that it doesn't appear to be so tight as in the diagnostic angiogram. So we did an RFR on this vessel. And just can you show the RFR results here, please? Go to the next one. Get the OCT screens, please. Yes. Can you see the OCT screens here? The PDPA is 0.99.
Yeah, we can see that right now. We can see the RFR came out at 0.98.
0.98. So it's definitely hemodynamically not significant. Even angiographically doesn't look very tight today. So after completing this, then we went to the left system. Show the left angiograms, please. Go to the left angiograms, please. Yeah. Next one, please. Yeah.
So you can see on the left, and this is the LAO cranial. You can see a very tight ostium of the left main. There is a bit of the ostium, and then the lesion, which is very tight in the LAD. This is after nitroglycerine. The LAD otherwise looks not very significant. So we first did.
And that intention was previous operator did an exact ostial positioning of the stent in the LAD. So now this is what the IVUS showed. So just go through the IVUS, get the IVUS. So we thought without dilating, we'll do an IVUS on this one. So this is what the IVUS showed. Play from distal, please. Yeah. Yeah, Jihad, any comments on this IVUS? We just keep playing. This is into the previous stent.
I mean, I think first of all, IVUS is the right choice for this indication. You have an ostial left main lesion, so you can mark it perfectly without needing to inject contrast. I think OCT is an inferior modality for this specific indication. Right now we can see your stent, which looked well deployed. You have some fibrotic plaque in the proximal vessel. Now we're getting quite tight.
Yeah.
And there we are in the aorta. So there's clearly what appears to be a modestly negatively remodeled.
Absolutely. Just show the measurements here, please. Just show the
heavily
measurements.
Fibrotic.
Yeah, can you see the measurements here? This is the lumen area. Just go distally. And it was only 2.75 was the left main size close to the ostium. And distally it just expands to close to 3.5. Significant negative remodeling close to the ostium. The lesion doesn't appear to be any calcium there in the lesion, appear to be a soft block. Most probably this is the cause for a syncope. Just keep moving inside, frame by frame. So it's not very big, right? Left main is not very big. Maybe it is 3.5 is what we got distally. And if you see carefully, keep moving. And actually the stent has extended beyond LCX into the left main. It has completely covered the LCX. So that's what we got from our IVUS imaging. And keep moving distally. Keep moving into LAD. Show that ISR area. There was some suspicion of an underexpansion or ISR in that area. We can't see much of tissue. Can you see something here, Jihad? This is done without dilating. See something at 5 o'clock?
Yeah, there seems to be something.
Yeah.
What's your minimal lumen area here?
Yeah, we measured around 4.1 something. So what do you think? We should address this one or just leave it?
I mean, honestly, since you've opened and paid for a pressure wire,
yeah,
I would not stent this without showing there's a significant gradient across it.
Yeah. So with that, there's little things whenever we find an ISR, always it is better to have a higher resolution modality than I think you accept, right? So it is so two problems we have. There is some suspicion of ISR in the stent, and the second one is as we from the IVUS imaging, we are sure that the stent crossed the LCX into left main. Because we are going to put a stent from left main to LAD, we thought we should characterize this stent carefully at the LCX ostium. So we did an OCT imaging after balloon dilatation of left main ostium. Can we see the OCT imagings, please?
So this is just for the academic interest of people to show you what imaging can do.
And we have dilated with a 3 millimeter balloon the ostium. So after that we did an OCT imaging. Just to switch to the OCT screen, please. Let Jihad comment on this. Just switch to this thing and stop when that ISR comes. First image.
We can't see the OCT yet, guys.
Yeah, okay. Yeah, we're just going to get you the OCT images. Yeah.
Quickly get. It is getting late. Yeah.
Okay,
so Jihad, what is your practice? Do you do an OCT if you have that you are suspecting that the ostial LAD stent come back into the left main to decide whether to open into the LCX before putting the second stent?
I mean, I would have typically done kind of all of this using IVUS. I think there's an advantage using OCT. Look at the quality of the images comparatively; it's just so much easier to see. So if you can afford to use both, obviously there's a lot of advantage there. I am a firm believer that in the ostial left main IVUS is the superior modality.
We did that then because we just wanted to just to slowly move here. Just see that the area was 4.1 is what we got with IVUS. Just see that smallest area here. So 2.62.
Yeah.
It's 2 point something, 2.6.
And do you think it is an underexpanded stent, Jihad, or neointima?
It looks like it because
it looks like it is an underexpanded stent, right?
I do believe this is an underexpanded stent.
Yeah,
if you look
absolutely.
at the reference markers by the OCT, the distal reference is 4.06. So this is probably an underdilated, originally deployed stent.
Come to ostium. Could you just quickly, for sake of time, go to the 3D view, please? 3D bifurcation here.
Critically, I would say there's very, very little neointimal hyperplasia. So that's working in your
favor. It is a predominantly underexpanded stent. And this is what we got at the LCX ostium. So it is clearly covered the ostium and come into the left main, right? The stent.
Yeah.
Yeah. So we thought we just optimize this ostium first before putting the stent inside.
Yeah. So what the plan was that there is an underexpanded stent. It's about 20 millimeters away from where the previous stent was. There is a lumen of the circ which is covered by stent. So the plan was, we thought because we now go putting another set of stents across it, so we need to be clear that the lumen is open in the circ. So we just wired the circ and we go to the angiogram now. So we wired it, and with a 2.5 balloon just gently open the ostium of the stent into the circ. Just to...
So let me ask Kevin and Dr. Mustafa here. So, you know, you've got probably about a 15 millimeter long left main, and you've got a stent protruding from the LAD into the distal left main. Are you double jailing the circumflex here, or are you connecting the dots in the very distal left main with a 12 millimeter stent? Kevin, what's your strategy?
Yeah, I think, you know, with the osteal disease, I mean, I'd be looking with this balloon to see a couple things. You know, I probably would do this case radially, in which case the guide and the stent move with respiration a lot. And so you got to be mindful of placement there, Ziad, because you don't want to miss on either side of it. So angiographically, I would love to be able to do that, but whether it's feasible is something I don't know the answer to, because there's a lot of tolerance of motion. I just mark the ostium, I think, as you suggested. And then with that, come in with a balloon and just shoot the system stable enough that it's not going to move at all while I'm trying to place a stent. Really, with a couple millimeters of margin on either side, it's going to be tough to potentially pull off, but that would be favorable. I think, you know, if you're able to maintain patency of the surface, I think you should be able to. And worst case is, you know, you may double jail it, but I think the maneuver that the team did to open the struts initially gently, so you had to recross and you were going to double jail, you'd be in good shape to, you know, kiss out or bifurcation or whatever.
So let me ask Ajit the question in the meantime.
Sure.
So you've now dilated the osteal circumflex.
Yes.
What about, because you have a left main lesion.
Yes.
What was your consideration about completing this as a culotte?
Well, I wouldn't do that. I just wanted to open that ostium up, because if we put a stent right across from the ostium of the left main to the underexpanded stent, which we would obviously fix with high pressure balloon dilatation with a single long stent, we would be putting a lot of metal across that circumflex ostium. So I just wanted the circumflex ostium to be opened up first. Well, if you have any issues, then we will think about it later. So this was a plan between me and Vijay. Yeah.
Okay. And Dr. Mustafa, what about you?
Good evening, sir. Dr. Ajit and Dr. Vijay. Very nice to see you, sir. Like missing the triple M cath labs like in the good old days. Okay, so in this case, actually, my preference is, as Dr. Ajit sir, you have done here, like open up the LCX ostium well, and then plan for extending from, left main ostium across the, extending it to the LAD. And even if there is a little bit of overlap, I think I will take it to that side rather than missing that overlap. So even if there is double metaling at that spot, I prefer that actually.
Okay. And Vijay, will you image the circumflex after?
Yeah, we didn't. Yeah, we did. And great. We dilated our this thing also, ISR spot also with the NC balloon.
Great.
Just show that. Yeah.
Now show the next OCT, please.
Yeah, team, I had one question. This drug-eluting stent in the LAD was placed very recently, so there's probably drugs still there, right, in terms of creating new injury in the area that was unexpanded?
I'm sorry, I didn't get that.
The LAD stent was placed within the past month. Did I get that correct?
Yes, that's correct. It's about a month. It's not. It's an under-expanded stent. I don't think there's.
Yeah, so there's still drug there, which is nice. That lessens concern that you would create a nidus for ISR and the balloon you're doing in the LAD.
So how did you pick your balloon, and what size balloon did you dilate your LED stent?
3 millimeter balloon. This is a 275 stent, so we use a 3 millimeter balloon to dilate it. And we checked in 2 views, looked a reasonably good dilatation, but this is what we got. You see that 3.41 it has improved to?
This is after the balloon dilatation of a 3O balloon at 20
high
atmospheres.
pressures. High pressures.
So
Yeah.
this
A
is
lot
what-
of negative remodeling, isn't there?
That's
Most
correct.
probably that may be the reason. I think it is not giving way a bit. But angiographically, you see, you can't see anything, right? You just see the angiogram here.
The angiogram
You
looks.
see the angiogram and the OCT.
Yeah. And just see the
Ostium of the
LCX
circ.
spot.
Yeah.
LCX, bring to LCX here. So get the 3D, please. Just remove the wire here. Just show that. So what do you think, Jia? That is reasonably well dilated, right? Our seam is wide open now.
I think the osteocircumflex looks great.
Yeah. And what is your take on this ISR, how to do that? So you just balloon dilate and leave it, or you just make sure that it is well expanded and put an additional stent, or extend the same stent to there? So what do you think we should do?
So this is just my take.
Yeah.
You have to basically twist my arm for me to put a second stent in,
Okay.
Okay.
right? I can tell you we have some burgeoning data that shows that
Euro intervention data, right? So that you publish.
once you put in a second stent, if the patient has a stent failure, they're done.
Yeah.
Nothing works.
Yeah.
And you're talking about a lot of complexity, a lot of expense. So I try to avoid putting a second layer of stent if at all possible.
So
You think it is a negative remodeling? Just leave it after this balloon dilatation, Jia? What do you think?
So did you, in the proximal vessel,
actually we dilated again with a 3 same balloon, scoring balloon, the same spot. Just show the next OCT, please.
So we were a little unhappy about that. You can see the pictures also. There's something on the down part of that balloon. Can you see that? You know?
yeah.
Yes.
And that's clearly under expanded there. So we went up with the 3O scoring balloon just to be sure that we get the best out of that lesion. And we got some benefit, but not great.
It is just improved to 3.5, not much. So what do you think we should do now?
So, the key here is to look for balloon sizing. Is there any segment within 5 millimeters of that lesion where you can measure the EL?
Yeah, just go distally.
If you can find any segment of EL measurement within 5 millimeters of that, I would size based on the EL and use that size balloon.
And we have IVUS also, we can do that, yeah. Just get an IVUS, this thing, and get a measurement, EL to EL.
Try proximally, because you're in the proximal half of the
proximal.
Yeah, we'll come
the
proximal, yeah.
Yeah, so come proximal to your lesion and see if you can find a segment of EL before the left main, and you can safely use that balloon because there's no branches.
Keep coming.
And if you can't, you're absolutely right. I would use the IVUS to size how big I could of a balloon I could use.
Just get
Yeah, I was going to say that. Yeah, as much as I love OCT
Come
for stent
proximally.
failure,
Yeah.
heavily
Okay.
stented
Go
or vessels
distally,
like this
distally,
where you
get
can't
distally.
see deep
Distal,
wall
distal,
structure,
distal,
there
distal.
is value
Other
to
way.
IVUS to
Keep going,
understanding
keep
sizing.
going.
In a male, 3O in that segment of the LED
Go.
seems like
Some
just
more,
by
yeah.
gestalt it
Come
was
back,
small. So I'd be looking for any
Just size
excuse
for
to
this
take
thing?
a 3.5 there, and I think the IVUS could help you with that decision.
No. Vessel. Just get
I agree. So I'm going back. If we use the Illumian criteria, this is lumen to lumen. We can round up to like at least 0.5 millimeter, if not 1 millimeter. So I'd be going with
I
the
think it's
3.5
a-
NC,
Yeah,
and I'd
3.5
be
NC.
moving it up.
3.5 NC, yeah.
Yeah, so can we have that IVUS? We've got that picture. Can you
Yeah,
just...
it is 375 was the vessel size with IVUS. So we go with the 3.5 balloon here.
So that's the IVUS now. So you can see that proximal. You can see it's about 375.
Even this is a very conservative measurement, even if this is 375. Yeah.
Dr. Ziad, in this case, actually, even if the vessel size is only 3, since there is such a, in a very short period, ISR has happened. So would you consider little oversizing the balloon? My preference is to do, even if I don't have an OCT to check the actual lumen diameter, my preference is to go straight away with 3.5. Maybe a little oversizing.
Mustafa,
Well,
I
the main
think-
issue, here without imaging is you don't know the mechanism of the ISR, whether it's neointimal hyperplasia or whether it's under expansion. Clearly, within a month, it's more likely to be under expansion, like in this situation.
Yes.
So I think the imaging is being very, very helpful here.
Yeah, so that was the point today, to show how various imaging techniques can show various things. And clearly you saw on the IVUS that even conservatively it looks 375. So we can safely go with the 3.5 balloon there, you know. And so,
And
so
I think I mentioned earlier, 20 atmospheres up for a longer period of time.
Yeah, we'll do
and
that.
really just let it sit there would be hopefully going to help this type of problem.
And, you know, conceptually, what we're trying to do here is we're actually trying to create some tears behind the stent. Not a perforation, but this is fibrotic, really densely fibrotic tissue. And we're looking for some segment to yield. That's why a prolonged balloon inflation with a larger balloon is more likely to give us some extra space.
yeah, so that's what we've done here. Now this is about
3.5.
3.5 at 20 atmospheres. We're giving
Yep.
a
And in
prolonged
this scenario,
diameter.
length matters. I won't take a 12 or a 15. It's typically an 8. It's focused right in the spot where the OCT and the co-registration tell me there's a problem.
Yeah,
So
so
you can
that's
show us the angiogram again,
Can
if you guys are
sh-
working.
Yeah, so can you show the angiogram, please? In fact,
Go
that's
back.
what we did.
Go
yeah,
back,
yeah,
go
yeah,
back.
Yeah.
Let's look at the angio and see if that previous sort of shelf-like structure before, it's starting to look better, I think.
Yeah.
Mhm.
Just show the cine image now. Maybe you can. Okay, we didn't record anything.
We'll take a shot now for you. Okay. Ready?
Yes, sir. Still at that area. You think it is recoiling something? What do you think it is?
Well,
Looked better
you know,
when we
it's definitely
dilated it.
better, yeah.
you've now used a balloon at 20 atmosphere size to the EL on 2 modalities. You're done.
Yeah.
Yeah. Okay.
Yeah, the hazard to going oversized here is a rupture. So
Yeah,
at
yeah.
this point,
Yeah.
you know,
I
it looks
wouldn't-
better.
At,
It may be imperfect, but I think to Ziad's point earlier, in these types of stent failure cases, you really are against the wall with limitations in terms of how much you can remediate it. So getting it right the first time is really the edict here. And when we inherit cases like this, there's a balance between overly aggressive and what's good enough. And I think based on what you've done, that angiogram, hopefully OCT will confirm, I would suggest you're probably done.
So, you know, I'm going to be the odd man out here and say that I would probably connect the stents in the left main. And if, especially if the OCT gave me a 12 or 15 millimeter length that I could come out into the ostium by a millimeter or two, I would actually not double jail the circ. And my rationale for that is you have, if you have stent boost, you have angiographic co-registration, you only need a millimeter or two of overlap. Your OCT showed you have at least 2 millimeters going over the circumflex. You know, putting 2 layers over the circ may not be the best long-term protection of the branch. And I think that there's little downside unless you really think that you may end up missing. Thoughts from the panel?
I think, you know, if you're short on the stent, let's say a 12 or 15 or close, you can always go a little longer. And I don't know if you have osteal flash there, but it's a way to kind of deal with a little bit of extra margin of length if you hang out a little more than you need to. But to Ziad's point, if you think you can pull it off, it would be optimal. It really is just a matter of how things line up and your ability to visualize. But IVUS marking the ostium and knowing on stent boost where you are may be ways to get that to happen where you don't miss on either side.
I think
As
the
doc-
key
as-
here is
as-
to use the imaging to make
Yeah.
sure that you have the length.
As Dr. Ziad said, since there is some, I mean, at least 2 millimeter stent already into the left main, it may be possible to, I mean, just overlap that without
Jailing the circ.
double jailing the LCX.
Okay, so let's go to the LAO caudal. So from the length, it looks from the circ, it looks about 15. How much is that length from the ostium of the left?
Ajit, why don't you use the OCT and the IVUS to measure it from the?
Yeah,
from-
that's what we're doing now. So that's what
Yeah.
we're doing. Exactly what we're doing.
No, no.
From the
Not that one.
Did you show the audience the OCT how you do that? I think it'll be
IVUS,
instructive.
Yeah,
ostium
let's show
too.
everyone.
yeah.
Just
But
show
in
that-
this
show the IVUS
situation, you need to have a custom-made size. Otherwise, like you will have to either hang
Ilpa,
too much of stent into the
just
sinus,
stent
or
ல
you will
இருந்து,
have to overlap into the LAD.
yeah, அங்கிருந்து ostium வரைக்கும்.
Right. So we can't see that just yet. So
I will show you
one-
that. So let's show the OCT first and show you the length. Can we have the OCT pictures first? Yeah. So here we are at the OCT
Just
trying
move
measuring.
one more frame proximally.
So that's the stent.
No, just you have to go to the frame where the LCX starts distally. Okay, move. Yeah, come back a frame, come back. When it gets rounder, yeah. That point you mark as a distal, and come
so
back proximally.
You can actually use your malapposition indicator bar here, because that will be the last frame of the stent.
Okay, that's a good idea. Yeah.
White portion.
And then have like a couple millimeters
No.
overlap. I can't see what that number is, but is it 18? It looks like it's maybe a 15 or something. I can't see. Sorry.
Yeah, so it is basically about 15. It's
Come
about
back,
14
come back.
point something,
Come back,
14.2 something.
No, come back.
So what we're trying to,
Come back. Yeah, keep it there. And this one is, I think, come back. No, come proximally. No. Ask towards the guiding side. Yeah, that we don't know exactly where it is. Maybe 13.5 is a measurement. Yeah,
So
let's keep it there. 13.2 is a measurement. Do the IVUS, please, quickly.
Yeah. Remember, you have the problem with the OCT catheter actually
Yeah.
getting sucked in during
Yeah,
and during the
absolutely,
injection.
yeah.
Let's use the IVUS.
yeah, we're showing you the IVUS now.
Yeah,
That's it. Perfect. Put a bookmark here.
Yeah.
bookmark. No, just to show that distal, yeah, that's correct, yeah. That is 12.7,
Yeah.
12.07, yeah.
So it's about 12.5 at a stretch for the IVUS, and it's about 13 point something on the OCT. So we will have to, put a 15 and sort of overhang it outside a bit, if that's the way we need to go, and avoid the sec.
I mean, I would be pretty comfortable with those numbers.
Yeah.
But obviously, you guys should do what you're most comfortable with. This was just a suggestion
Okay.
from my point of view.
Yeah.
I think those. If you look at the longitudinal image, the left main, it's not perfectly flush. You can see it's at an angle.
Yes.
So your 15 millimeters may actually end up quite favorably, touching the proximal segment of the aorta and distally be sticking out a few millimeters.
Yeah. So what we're going to do is take, I don't know whether we have a need a 3.5 stent. What do we have in Onyx 3.5? Okay, so we will use an 18 Onyx. That's the one we have here. So
I see.
we maybe have to push in a bit into the ostium.
I understand. I mean, that's a reality. So if you have an 18 millimeter stent, then it's better to just overlap and make sure that you don't miss on either direction.
Yes, that's right. So we'll get a 3.5 18 Onyx, and then we'll show you an OCT after that. So let's get the stent in, please.
We've got 10 minutes left, so we're gonna jump back to Arena 1 and hopefully be able to join you. Beautiful example of how intravascular imaging can help you make complex decisions. Hope to see you soon.
Thanks,
Thank you.
thanks, Ziad.
Thank
Thanks very much.
Good
Thanks,
job, team.
Kevin. Thanks, Kevin.
Well,
Thanks, Mustafa.
See you, sir.
Well, Moto
See you, sir.
Yeah.
Already connected, yeah.
Can you see us and hear us, Mustafa?
Yeah, yes, sir. Very
Okay.
well. Yeah.
Okay, so let's just quickly show you what we did. So we had an 18.35 stent, and can we have the angiogram pictures here?
How was the length? Was perfect or?
The length was a couple of millimeters extra. Obviously, just as we expected, the 18 would be a little. So that's just placed a few millimeters outside the ostium of the left main, and just across into the circ. So we had this issue that what we discussed, and Ziad said that we may have to cross into the circ when we get this 18 millimeter stent. So we had a few millimeters into the LAD across the circ.
So it was 18, not 15, huh?
It was an 18, yeah. So
Okay,
let's
okay.
just so next shot, please. So that's the high pressure with the balloon outside. And then we'll show you the IVUS now. Can we see the IVUS there, Ziad and Mustafa?
Yeah.
Thank
Sir.
you. So, okay, so what we
Vijay,
can see so far is a single layer of stent so far.
Yeah.
A nice circular lumen, big lumen areas, very little, no tissue prolapse that I can see easily.
Yeah.
Just focus that area, go display.
So it's probably that prior error from the LED.
Yeah.
Yeah.
So that looks better. That area which
Yes.
was dilated with a 3.5 looks much
The
better.
MLA there.
Yeah. So it looks better. And
What was the MLA? It was like 5 or something, so that's much better.
5.35.
Yeah, 5.
Better. Good job.
5.35. Yeah.
Excellent. So that's a success.
Yeah. So then we come back. That was the, and this is the stent, and you can see it's a bit underdone there, so we will go up 3.5 with a higher pressure, and you can see a few struts
your
into
strut.
the left
Yep.
main. Yeah.
And
Okay,
there's your left main.
yeah.
Good. So you probably have like 2 or 3 millimeters in the left main. I noted that you're very careful with your guide placement once the left main stent is out. So that's very good technique, of course, for everybody in the audience. You really want to avoid you getting sucked in with your balloons and then mangling the proximal edge of the stent, which increases your risk of target vessel failure by at least 2.5-fold. Happened in about 6% of the cases in Excel.
So we're just doing that ostium of the left main with a higher pressure. So this is a 3.5 at 24 atmospheres, just to open it up as much as we can. All the time the guiding is floating, and it's not in the touching the struts. Okay, and then I use that balloon quietly to get the guiding catheter in so that it doesn't touch anything, and then pull the balloon out, and we take some shots now. Okay. So I think we got a few minutes. We'll take some shots and show you what we did.
Yep, we're slightly over time, so maybe just a final angiogram, and then we'll
Yeah.
So that's the left main. I'm
Looks
just
great.
Yeah, so I'll just hold the wire there for the final IVUS, but just show the LAO caudal, please, one more view, and then we'll take the IVUS down. Yeah.
So would you like to flare up the ostium at least by 4 millimeter balloon, sir?
No, because it
no,
was pretty much well done.
Well expanded.
Yeah, well expanded, and we don't want to.
That ostium was only
Well opposed also, well opposed.
2.75 on IVUS. It's a negative remodel ostium, so we already dilated to 3.5. So we didn't try
This
the
is
4
you
millimeter
can actually
balloon.
see in this view a very nice example of their proximal optimization technique, as the stent is large just up until the circumflex. So that's very important to do a pot to your circumflex as part of the provisional technique here.
Yeah, so if you don't have time, we'll click off, but I'm going to do a final IVUS, Ziad and Mustafa and Kevin. If you have time, then I can show that to you quickly. Yeah.
So we just have about 3 minutes left, I'm told by our moderators. We want to stay on time and be respectful of other people. So what we're going to do is probably just jump back to Lucknow for just a minute or two.
Yep.
And beautiful result, beautiful use of intravascular imaging, both IVUS and OCT to guide a complex PCI with complex decision making. So thank you, Dr. Vijay, Dr. Ajit. Nice to see you, and fantastic work.
Thank you. Thank you.
Bye,
Thank
bye,
you,
bye,
everybody.
bye.
Yeah.
Great job.
Thank you, Kevin. Thank you.
Namaste. I'm Dr. A. Srinivas Kumar, Consultant Cardiologist, Director Cardiology and Clinical Research, Apollo Hospitals, Hyderabad. Greetings from FACS Foundation in TCT India, South Asia 2021. This live case learning series gets you interesting case learning findings regarding the interesting case of ostial left main and the proximal LED ISR lesion, very well demonstrated by Dr. Ajit Mullasari and Dr. Vijay Kumar from Triple M Chennai. The interesting aspects of this case were obviously the comparison between the intravascular ultrasound and OCT imagings and how they compared with each other in the diameter estimation as well as length estimation was very well effectively shown with side-by-side comparisons of both OCT and IVUS. I think this is a highlighting point of all the live cases this year in the TCT. We all are aware that OCTs significantly underestimate the diameters, and that's how we tend to take EL to ELs. But in spite of that significant underestimation of the diameters by OCT was clearly shown, where the IVUS showed a diameter something like 3.5, whereas OCT showed diameters of 2.5, 2.6. So significantly, and OCT underestimates the diameters, but we need to have our wisdom in place and probably not to stretch it too long, too high, to higher diameters. Probably add about 0.5 mm to the OCT assessment diameters, and also take into view what is the expansion size compared to other areas, and then decide whether to take a bigger sized balloon to further expand. This interesting patient, 70-year-old male, who had anterior wall MI and then primary PCI was done with a long LED stent starting from ostium to mid LED, and patient LCX was all right, and also the RCA had some mild disease. Initially, RFR was used to show that RCA lesion in the mid segment was not important. Then went on to the left side imaging. Because of ostial LAD, ostial left main was involved, and this fact was very clearly projected in the elevocranial views shown, where the left main, after little of leaving of ostium, had a critical stenosis in the proximal portion to the mid portion, and then the lesion in the LAD looked like mild an angiogram, but again it was later studied with IVUS and the OCT. And the IVUS measurement showed at one particular point where the ISR happened, it looked like significant under-expansion is the cause for this sort of appearance. Obviously, recently done PCI, there's not much of neointermal hyperplasia, but there is definitely under-expansion of the stent, leading to shorter areas at that particular point in the proximal portion of LAD. Another important aspect which was very well demonstrated by OCT imaging was the extension of the so-called where the operator must have thought that is placing the stent exactly in the ostium of LAD, but it crossed over the LCX ostium and came into one or few struts came into the left main, and then this was very well demonstrated by the OCT imaging. And because the plan was to also take a left main covering from the ostium of the left main to probably extending into the LAD proximal portion underdilated, the struts of the left LCX ostium were dilated a little with a 2.5 balloon, so that there should be less of material across the LCX ostium. And the discussion was also to measure exactly from the ostium of the left main to add 2 mm for the proximal protrusion, and to come just to the proximal portion of the stent and where the struts were getting into the left main. The measurements were compared both IVUS and OCT wise, and both almost showed to the precision extent of 1 millimeter, probably 12.5 or so by IVUS and about 13.5, 14 by OCT, including those minimal protrusion into the aorta. But as the truth goes and the reality goes, on the shelf 18 mm stent was there, and 3.5 18 mm stent was deployed, and then that went on to cover LCX ostium also into the underexpanded portion of the stent, and then afterwards then the proximal portion was optimized with a bigger sized with high pressure balloon inflations of 3.5, because artery opposition was very good and artery had a lot of negative remodeling and with very good expansion, and final areas obtained were quite satisfactory, measured by IVUS. And the LCX was also flowing well without a problem, and then the instant restenosis area of the LED proximal portion was also dilated well, and the final areas there obtained were very well. The other important aspect which was also highlighted in such minimal stent protrusions into the aorta were how to carefully handle the protruded part of the stent so that it shouldn't get distorted. So always exchanges should be done over the wire and the balloons when it is there. Probably carefully you take the guide catheter tip into the left main stent, and then probably dilatation should be done after withdrawing the guide out. And don't keep the guide out and when you're doing a dilatation, so that repeated in and out and then movements across the proximal protruding portion of the stent in the aorta could be avoided. Dr. Ziad Ali, who was moderating the session, mentioned that in Excel, there were 6% of the patients had such stent distortions, leading to increased. Some patients had stent distortions, leading to 6% TLRs in follow-up when the stent's proximal portions were distorted with the guide catheter movement. So that's how it is very important to handle the ostium of the protruding stent carefully. And finally, the patient had a very good result where left main was tackled, and effectively this was very well demonstrated in the end with intravascular ultrasound again, showing the proper stent expansion and good apposition with good left main area. Hope you all like this excellent comparison of both intracoronary imaging modalities with advantages and disadvantages of each of it, and probably effective tackling of the left main lesion and with proper tips and tricks to avoid proximal stent protrusion distortion in this such sort of patients. And we are extremely thankful for the excellent demonstration by Dr. Ajit Mullasari sir and Dr. Vijay Kumar, and hope you all enjoyed this live case transmission video and also the live case learnings. Thank you. Yours, Dr. A. Srinivas Kumar.